Okay. Dr. Tamiz, you can.
Yes, sir.
First of all, you switch on the video. Yeah. So, Dr. Tamiz will going to present the journal club. You can share your screen.
Yes.
सर डॉक्टर पंकज जी आपकी है ना वीडियो शो नहीं हो रही सर.
Sir, is my video visible?
Yeah. Yes.
Yes, sir. Can I start, sir?
Yes, please start.
Okay. Good evening, everyone. So, today we are going to discuss about a study regarding the optimal vasopressurization in septic shock, which is called the OVISS study. It is based on a machine learning. So, it's the reinforcement learning study. It was published in JAMA in March 2000.
Tamiz, your voice is not clear.
Voice is not clear, sir.
You have to come forward because it is there is some disturbance with the voice. Yeah.
Okay, just a minute. Sir, is it okay now?
Yes.
Okay. So, continuing with the study, emergency care in sepsis includes both fluid therapy and vasopressor therapy. Regarding vasopressor therapy, international guidelines recommend norepinephrine as the first-line agent and vasopressin as the second-line agent in septic shock. But septic shock is a dynamic condition in which the decision to start vasopressin is very complex. So we don't have much evidence from the RCTs also for the optimal timing for initiation of vasopressin. So for such a complex dynamic problem like septic shock, reinforcement learning, which is a branch of machine learning, it can be very much helpful. So this study uses reinforcement learning for derivation and validation of optimal vasopressin initiation rule in septic shock. So before going into the study, just a few slides regarding the literature review on vasopressin in septic shock. So in early 2000s, many retrospective studies and small RCTs showed that there is reduction in the norepinephrine requirements with vasopressor use without any obvious adverse effects. So based on this, a big trial was conducted in 2008, which is a landmark vast trial. It compared the norepinephrine and vasopressin in septic shock. I'll be talking about this trial in subsequent slides. So later in 2009, post-hoc analysis of the trial was done, comparing it with steroids, where they found a possible benefit. So later, with this addition of steroid, comparison of norepinephrine and vasopressin were conducted in another large trial in 2016, which is called the VANISH trial. So based on the results of this trial, even surviving sepsis guidelines recommended vasopressin as the second-line vasopressor in septic shock. So we have recent meta-analysis also that which suggests vasopressin reduces the catecholamine dose, and it also shows that it is as effective as norepinephrine, but without any mortality benefits. So this is the VAST study, which is published in NEJ. It is a multi-center study which had 778 patients. Here, the population group is a septic shock patients with norepinephrine, in whom it is going at around 5 mg per minute. So here, in the intervention group, they used vasopressin, and in the control group, they continued noradrenaline up to 15 mg per kg per minute. Their primary outcome was 28 days mortality. So the result showed no significant difference between the 28-day mortality between norepinephrine and vasopressin group. But they did a subgroup analysis also in a separate study. In a subgroup analysis, there is in a separate stratum with the less severe septic shock. The study showed significant mortality difference in 28-day mortality and also in 90-day mortality that we can see from here. So the stratum they've defined as less severe shock as in whom the in patients in whom the norepinephrine levels are 5 to 15 mg per kg per minute, and more severe shock as minimum 15 mg per kg per minute of norepinephrine. So coming to the next study, this is a VANISH trial published in 2016. It is also a multi-center factorial RCT. It had 409 patients. The population group is the septic shock patients in whom shock onset was taken within 6 hours. And they compared similarly norepinephrine with the vasopressor with or without steroids. Their primary outcome was not the mortality here, it is the kidney failure free days. And in the secondary outcome, they used RRT days and mortality along with adverse outcomes. The study result also showed no significant difference in the kidney failure free days in the vasopressin group compared to norepinephrine group. But there was, in the secondary outcome, there was less use of RRT in vasopressin group compared to norepinephrine. Otherwise, there is no significant difference in mortality or in the adverse effects. So coming to the evidence, what we have regarding vasopressin in septic shock, efficacy-wise, it is effective as second-line vasopressor after norepinephrine in septic shock. This is supported by a VAST trial and VANISH study also. Mortality difference, there is no mortality difference significantly with vasopressors in vasopressin, but there is a significant mortality reduction in less severe septic shock patients, as seen in the VAST study. Renal outcomes, it reduces the need for RRT, suggesting some nephroprotective effect as shown in VANISH trial and in one meta-analysis. Adverse effects, it can cause ischemic complications because of the vasoconstriction like digital ischemia and other skin lesions, especially if there is associated high norepinephrine use and along with the peripheral arterial disease. So when to stop vasopressin? This is published in one meta-analysis where they show that stopping vasopressin before norepinephrine increases the risk of hypertension significantly, suggesting that norepinephrine should be weaned first during the recovery. So these are the evidence we have, but when to start, what optimal timing for initiation and the strategy for dosing, there is no clarity in this. So this study is based on this, when to start vasopressin. So coming to the methodology, it's a cohort study which uses reinforcement learning model, which is a type of machine learning model. So here the study was reported according to the tripod plus AI guidelines. Here they have used the electronic health records from 232 hospitals, and it was conducted between 2012 and 2023. They've used data sets from data from 4 data sets, which is one is UCSF and UPMC, which is the University of California and University of Pittsburgh. Along with that, they used data sets from MIMIC4 and EICU CRD. So it is a certified de-identification, remove that institutional review approval and all. Coming to the objective, based on using the reinforcement learning model, they wanted to derive and validate a learning model to determine the optimal initiation rule for vasopressin in critically ill patients receiving norepinephrine. The outcome parameters, in the outcome parameters, primary outcome was in-hospital mortality, and the secondary outcomes were the use of mechanical ventilation and RRT. So coming to the cohorts group, as I mentioned earlier, there are two cohort groups. One is derivation cohort and validation cohort. Before that, which all patients they've included. In the inclusion criteria, they included patients with first episode of community onset or hospital onset septic shock, met in either ICU or ED, who is already receiving norepinephrine. So in the derivation cohort, they used UCSF set, that is California San Francisco data set, and with the training and testing data set. After deriving a model from the derivation cohort, they validated in both UCSF data set and in 3 other external validation sets, which I have mentioned earlier. So it was conducted roughly between 2012 and 23 in various hospitals, and the number of patients included and all I will be discussing in the subsequent years. So coming to reinforcement learning model, it before going to the study, I'll be explaining briefly about the model and some terminologies. So in the model, we have an agent, we have an environment along with the action, state, and the reward. So what is an agent? Agent is the decision maker, which makes a decision or a move, which can be a software, it can be a robot, or it can be some model based. And what is an action? It is the decision that an agent takes or the move that an agent takes. So environment is what the agent interacts with. and it gives feedback to the agent. So the state, it is a snapshot of the environment at any given point of time. The reward can be told as a feedback signal from the environment once the action is taken from an agent. So this sequence of events keeps on happening, and each sequence is called a trajectory, which can include a sequence of state, action, and the reward from start to end. So basically, here with the reinforcement model, a virtual agent, this I can like virtual agent learns an optimized set of rules with the decision making by trial and error by interacting with the environment. So here agent takes an action over the environment, like it's basically a decision. From the environment, it gives it assesses the state of the environment. Also, it gets a feedback signal through a reward. So with the state and the reward, it again analyzes the model and it changes its decision next time for a better reward. So this keeps on happening continuously with trial and error. It learns an algorithm or a rule that forms a model that gives us the model for proceeding with the next group. So this is what they have mentioned in their article in the supplement. So basically, it analyzes the state of the environment can be assessed with the vitals, lab values, and the procedures. So with that, it is transmitted to the RL reinforcement learning agent, and this agent makes decision. So based on the state of the model and based on the next reward, it makes an apt decision that forms a rule, optimal rule for treatment, and this cycle goes on. So this is what an agent model does. Here, based on the state and the reward function, the input is derived. Input is given by the agent. So it gives the input in the form of Q function. Q function is basically the intelligence or the performance aspect of the agent. So what it does is it does an action based on the current Q function. So once an action is done, this Q function is updated using the observed rewards. Once an action is taken, it forms a reward. So with that reward, it updates itself for the next reward and with the predicted Q values for the next effect. So with that repeated cycles of decisions, it refines itself and it learns a new set of rules as I've discussed earlier. So that is why it is called as reinforcement learning. So with that, it forms a policy and that is applied over the certain data. So basic of model I've explained. Now what they did in the study, I'll be explaining. In a model training, they did with an epoch. Here there is a term called epoch. Here epoch means a time frame. In machine learning, epoch is the time frame or the time pause that each interval has. It's basically, it can be termed as a time interval. So here the time interval is 1 hour. So what action it gives? Action it gives is a binary decision. Either it tells to start vasopressin or do not start vasopressin. And what's the reward that it gets? Reward is basically the outcome. So here they have mentioned the rewards as the either in-hospital mortality, changes in the lactate, MAP, SOFA score, and the norepinephrine dose. They've also mentioned regarding the gamma factor, which is a discount factor. It is set at 0.99. So here the gamma factor ranges usually from 0 to 1. As I've discussed about the rewards earlier, this reward can be an immediate reward or can be a long-term reward. The immediate reward can be, for example, if the machine agent tells to start vasopressin, if the change in MAP or the change in lactate levels can be the immediate reward. But the change in mortality or change in SOFA score can be a long-term reward. So based on the effect we need, it can be set either at the level of 0 or it can be kept at the level of 1. So here they have kept at 0.99. Probably they are also taking mortality into account as a primary outcome. So what data they prepared for the model training? So here each hospital stay is taken as a single trajectory, and the time interval they have taken for one epoch is the 1 hour. So started at 1 hour after the shock onset. So when did they terminate the data? They terminated data based on these three categories: either earliest of the shock recovery, that is 12 hours after the norepinephrine started, or either at patient's ICU discharge. Patient can be dead or can be alive when they are discharged, or if the patient crossed 5 days interval, that is 120 hours. So the 1 hour epoch, they were describing it with 4 clinical parameters, which includes vitals, lab values, and organ support. So these are the parameters that they have discussed. So once the agent takes a decision regarding starting vasopressin, either starting or stopping, it is based on this parameters. So it assesses, this is the state of the environment. It assesses MAP, norepinephrine dose, shock onset, SOFA score, and based on the repeated trial and error method, it changes its values and gets the reward, and it changes its next decision for a better reward in the next cycle. So coming to statistical analysis, continuous variables were mentioned in mean or median, and the categorical variables were mentioned in percentages. P-value less than 0.05 are considered statistically significant. So they have mentioned analysis at various levels. One is for evaluating the reinforcement learning rule, and another analysis is for the implications of that rule. And also they have mentioned the statistical analysis to check the robustness of the results, and for the sensitivity analysis also. And also they did analysis to enhance interpretability of the model. They used sharp values. Also they have assessed the model fairness and equity. So coming to evaluation of the reinforcement learning rule, they used weighted importance sampling. So with the weighted importance sampling difference, they evaluated the performance of the reinforcement learning rule. How they did? Basically, they compared the mean reward obtained with the reinforcement learning rule with that of the clinician observed actions. This clinician observed action is what we have from the retrospective data. And this reward obtained from this oral rule is what would have happened if this rule was applied in that data. So since RCT it cannot be done prospectively, they have done it in the previously existing data. So they compared the mean reward of the data from the oral rule and that of the clinician observed actions, and they compared it. They did for both internal validation set and in the external validation set, and also they compared the overall reward along with the individual reward components, which I mentioned earlier. So coming to treatment implications. Okay. I'll be just explaining what the analysis they did initially, and the results will be displayed later. In the treatment implication, they checked it in the 3 external validation sets. Here they have used pooled logistic regression to estimate the adjusted odds ratio for in-hospital mortality. Basically, they've compared 2 groups, like in whom the care was similar to that of the oral-based rule with that of the clinician-based actions. So with the 2 groups, they have compared for every hourly with a time block. So to account for the time varying confounders, they used inverse probability of treatment weighting. And apart from this, they did an adjusted odds ratio analysis with the simple rules for vasopressin initiation in the existing clinician-based actions. Like, what is the odds ratio for mortality if the serum lactate is more than 4? Or what if it is started at 0.7 mics per kg per minute? And what happens to mortality if the MAP is less than 65, or if it is started more than 12 hours from shock onset? So along with this, they did a survival analysis also. So also they have mentioned with the oral model, comparing with the clinician observed actions, they've mentioned regarding the percentage of patients who receive vasopressin, and what is the timing of initiation relative to shock onset, and at the time of initiation, what was their norepinephrine dose and the SOFA score and the serum lactate. So robustness of the results, they compared by 3 methods. One is by calculation of e-values, another is by falsification analysis. Also, they've included both ICU and hospital level features and checked the robustness. On the sensitivity analysis, they've done the sensitivity analysis in restricted cohorts, like in 4 groups. One in which the vasopressin was advised and was actually started, and in whom it was advised against vasopressin initiation. and they've excluded AKI patients in one cohort, and also they have checked the analysis in whom vasopressin was started within 48 hours. So apart from these restricted cohorts, they also assess the values with varying gamma levels, like 0.9 to 0.95 and then 0.9. So they've also repeated the model with 2-hour epochs. The original study was done with 1 hour and it was done with 2-hour epochs, and they have repeated with the alternative weighting for the reward also. So interpretability was done with sharp values to check how each factor in the model has contributed for the prediction. So in the model fairness and equity, basically they did a subgroup analysis. So whether in male and female, whether there is any difference. Along this subgroup analysis was done also in the race and in the age group. So coming to results, basically they have admitted 4,99,596 patients, of which 4,82,336 patients were excluded. So effectively they included 14,453 patients. So in this, they've taken 3,600 patients in the derivation cohort, and with the derived model, they've checked this basically validated in the validation cohort in the four data sets. One is in the internal validation set, which is from the UCSF data set, and the other external validation sets were the UPMC, MIMIC4, and EIC. So these are the patient characteristics. These patient characteristics were comparable between the derivation cohort and the internal and external validation cohorts. And these are the vital values and present at the time of initiation. These data values are also roughly it is comparable between both derivation cohort and validation cohort. So coming to the organ support, the basic dose of norepinephrine at the time of initiation, vasopressin introduction. So there were some differences in this. At the time of initiation, in all the cohorts, the dose was roughly 0.1 mg per kg per minute, except in this EICU CRD group, where it is roughly 0.26. And in the during shock, vasopressin was introduced in roughly 20 to 25% in all other cohorts. In MIMIC4, it is corresponds to 48%. And at the time of onset and during the entire trajectory, mechanical ventilation was present in roughly 20% in other groups, but it is comparatively higher in the UPMC group. Other kidney RRT and outcome parameters are also comparable between them. So coming to the evaluation of reinforcement learning group, as I've discussed it earlier, they did it with the weighted importance sampling, and the sampling difference came out to be significant when they did comparison for overall rewards and also for individual rewards. It is better in the oral based group. So that we can see from the results here. So only in the internal validation set, the difference was not statistically significant from the confidence interval crosses to the other side. But in other groups, it was statistically significant. So this is the data that they have compared between the oral rule group and in the clinician observed actions. So coming to the primary and secondary outcomes, the in-hospital adjusted odds ratio for in-hospital mortality was better in the oral group compared to the clinician observed actions. So it is not only in the overall value is also better, and in the individual external validation sets also it is better. Coming to the secondary outcomes, RRT was also lesser in the oral based reinforcement learning based group compared to the clinician based action, but mechanical ventilation did not show statistical significance. So this is the adjusted odds ratio overall, which they have put it in a diagram. The overall odds ratio is less than 1 in overall group, also in the external validation sets. When this is the comparison of this is the adjusted odds ratio in the clinician observed actions with the simple rules of vasopressin initiation. Like what if the serum lactate is more than 4? We can see from the diagram that odds ratio is more than 1, and it is showing high risk for mortality. Similarly, when norepinephrine dose is more than 0.7, the mortality is higher. Similarly, if MAP is less than 60, when we wait till MAP is less than 65 or for 12 hours after shock, the mortality is showing the mortality risk is showing higher. So this is the survival analysis curve. Here they've compared between the two groups where the care given in the group was concordant with the oral rule and which is non-concordant with the oral rule. As we can see from the graph, the survival analysis shows better survival probability with the group which is showing concordance with the oral rule. So this is the diagram showing here the y-axis refers to randomly selected patients. Roughly they took 100 patients value, and the x-axis they have used the time, like every hourly they have shown. Here the purple values shows the addition of vasopressin, and the red bar shows the dose of norepinephrine. So from 0 to 100, it is showing the trajectories of 100 patients. So from the in the left side, it is the clinician observed administration of vasopressin. Right side, it is showing the treatment recommendation as suggested by the reinforcement learning group. So from the comparison of the two diagrams, we can see that the purple color is very much lesser in the left side group, which is very much higher in the right side group. It shows that the vasopressin was initiated in higher numbers in the RL based group, and it was also started at a very earlier stages. From here we can see it was started in less than roughly 10 hours. So, but here in very few patients it was started very early, and it was not started in many of the patients. Also, it is showing the uh, the red dot shows the death of the patient, and in which there is no red dot, it means the patient is alive. So basically, this chart shows that vasopressin was initiated early in the RL based group, and it was started in higher numbers in the RL based group. So this graph also shows that at what time point in how many patients the vasopressin was initiated in clinician observed actions and in reinforcement learning rule based group. So from two graphs we can compare that it was started higher in numbers in in oral based groups in a very early stage. So it was started in roughly 4,500 patients in the first 5 hours, and in roughly 3,000 patients in the next 5 hours. So, but here it was started roughly in 1,500 patients only. So they have also mentioned at what doses they have started vasopressin, and in how many patients they have started vasopressin, and at what in the time since shock onset, at what point of time they have started vasopressin, also with what SOFA scores and at what lactate levels they have started vasopressin. So this shows the overall group, and this shows the individual external validation set. So from here we can see there is comparatively a larger difference in whom the number of percentage of patients in whom vasopressin was started. It was started in 87% in the RL based group, and it was started in 31% in the clinician observed actions. So similarly, the dose at which vasopressin was started in RL based group is at 0.2 mics per kg per minute, whereas in the data it was started at roughly 0.37 mics per kg per minute. So it was similarly in all other external validation state. Reinforcement learning based group started vasopressin at a very lower norepinephrine doses at roughly 0.2. Only in that EICU CRD group it was started in 0.3. So time since shock onset, in all the groups, it was started early in the oral based group compared to the clinician observed actions. Only in the Mimic4 databases, it was started early in the clinician observed actions, like at 4 hours, and in the oral based group, it was started in 5 hours. SOFA scores, similarly, it was started at a very lesser SOFA scores itself. And the serum lactate were also lesser when they started vasopressin based on the RL based group. So coming to the robustness of results, the analysis was supported with the E-value of 1.46, which also proves that it was not changed with the confounding factors. Also, they've added some hospital and ICU-based characteristics. Even after that, the odds of mortality, that adjusted odds ratio, was consistent. So the confidence interval was just touching the unity. They've mentioned that odds ratio is still consistent. And the falsification analysis also did not show any significant association when they changed the either the outcome or the exposure. It was the adjusted odds ratio did not show any significance. So this is the sensitivity analysis. Here, as I told earlier, after changing the hospital or ICU characteristics, it did not, the odds ratio did not change. Odds ratio for the in-hospital mortality did not change much. Also, when they did the sensitivity analysis in restricted cohorts, like in whom only vasopressin was started, and in whom vasopressin was started within 48 hours, and in after excluding AKI patients, all these three categories, it is still showing significant difference, that the risk is very much lesser for the mortality group. But in other groups, it did not show statistically significance, like when they adjusted the gamma values to 0.9, or when they used 2-hour epochs, or when they changed the weighting. So it did not show significant difference. At the same time, it did not show higher risk for mortality. So this is the sharp values to see the weightage for individual parameters, how much each individual parameter is contributing for the outcome. So from here we can see they have mentioned that the shock onset, time since shock onset, SOFA scores, and the norepinephrine dose, serum lactate levels, they contributed much among the model that the reinforcement learning has chosen. These 4 parameters contributed individually for the higher scores. So this is the subgroup analysis they've done in the age group of less than 65 or more than 65, and in male, female, and in the different races. As we can see from the graph and this whisker box plots, there is no significant difference between them. It was comparable between them. So coming to discussion, compared with the clinician actions, reinforcement learning based rule to initiate vasopressin was associated with higher reward. That is, the outcomes were better with the oral based rule, and it was associated with reduced in-hospital mortality. This study is the first to evaluate reinforcement learning method to aid in decision making for vasopressin initiation and septic shock. These findings, which I've mentioned earlier, it aligns with the subgroup analysis of the VAST study, where they have shown that the mortality, the survival, there is a mortality benefit in the less severe shock stratum. So the rule for vasopressin initiation based on this model improves outcomes by several mechanisms. They have proposed 5 mechanisms in which they are mentioning that the mortality benefit may be because it captures the subclinical features very early, which may not be seen by the clinician in a real time. Also, it says that the exogenous vasopressin compensates for its relative deficiency in septic shock, and that is why it is providing benefit with mortality. Also, they mentioned that it increases GFR, which is consistent with the lower need for RRT, which is the secondary outcome of the study. This has been shown in the VANISH study also. So prior studies, VANISH, VAST, also demonstrate catecholamine sparing effect, reducing the arrhythmias and myocardial ischemia. So it is advantages here also. And they have also mentioned that increased vigilance and monitoring because of the addition of second agent also adds to the additional benefit. So coming to the limitations of the study, as we know, this is taken from the cohort study from the data sets which is available already. So they did not test it prospectively. They just used an offline data. That way it is not so much reliable. And they did not include low and middle income countries in their analysis. So it is not so much generalizable also. And the factors like the clinician subjectivity at the time of worsening of the patients were not fully captured by the model, since it takes just the values and the lab values and the vital parameters. Human factors were not taken into account. So here, and also they mentioned that it did not include the unmeasured variables, like what is the source of sepsis and what is the timing of initiation of sepsis. They mentioned that missing values were replaced by just last observed values or by the mean of the values. So data related variability can occur. Also, the model just evaluated vasopressin initiation in the study, but they did not tell about any strategy or dosing for increasing or decreasing or weaning. When should we wean? That those points were not mentioned in the study. And they were also not mentioned regarding the long-term outcomes, like the functional outcomes or cognitive status, over long-term period in the survivors. This could have been evaluated. That also they have mentioned in the limitation. So coming to conclusion, in adult patients with septic shock receiving norepinephrine, the use of vasopressin was variable, as we have seen from the literature review also. So this reinforcement learning model, developed and validated in several observational data sets, recommended more frequent and earlier use of vasopressin than the average care patterns. And this earlier and frequent use was associated with the reduced mortality in the study. So coming to critical update.
Dr. Tami,
Yes, sir.
before we will discuss the study before going for the last critical appraisal.
Okay, sir.
So, Dr. Jitendra,
Yeah, thank
yes,
you, Dr. Thamiz.
Yes.
There are a lot of, you can say, uniqueness in today's General Club. One, this is the very unique study method which was used in this particular research. So we'll discuss a few part how the AI, all the time we are discussing the intrusion of the AI, not only the clinical practice, the trial design is also revolutionized here.
Yes.
So we'll little bit pay attention and give some time to really understand that we can use the maximum information from this paper, not just to again whether the conclusion is right or near to the truthfulness or not. That obviously that would be our part. So typically first question comes at the why the need of the study, which you clearly mentioned. Till now we don't have a randomized control trial related to the vasopressin use. Yes, Vanish trial was randomized control trial, but not with the endpoint of the ICU mortality or heart point. That was from the renal replacement and the from the renal outcome basis. So that's why we still don't know from the our modern way to reveal the truth in the medical practice in the form of evidence-based highest weightage is the randomized control trial with the very good design and all these things. Obviously, that was now just a simple here is we divide the trials into different kind of so can you say what kind of this trial is from our conventional way to way we actually categorize a trial? So what kind of this trial is?
Sir, this is basically a cohort study. It's I would say it is not a randomized trial. It is a cohort study, which from the previous patient data, and they have used a model. Like they used one algorithm as model, and they validated.
That we understand. Yeah. So, so now if I say, do you agree with me? This is a retrospective trial.
Yes, sir, kind of.
This is the comparative retrospective trial because outcome already happened.
Yes.
And you are seeing the data. So classically, it is a retrospective trial in nature. How we divide the trials into the prospective, retrospective, comparative, and cohort. Why I'll say a comparative? Because of course the cohort. So don't get confused. Still, I am not entering into this classical way of doing, because here when they use the word cohort would be different for this trial. That would be for external or internal validation word for the cohort. I am using here what we conventionally use the cohort. Here, if you say is a comparative. Comparative is a no vasopressin versus vasopressin, and so classically it is a retrospective trial, but a retrospective trial with the very enormous ability, maybe out of the human way, to consider all the variables with the help of, we will discuss even the reinforcement learning. That's why we can't label it as it is almost the same retrospective trial which we are talking about. Though it gives you a flavor of the retrospective trial in nature, but it can't. Why? I'll say because when we do the retrospective trial, there are a lot of human limitation, and we look at the data. And here, we'll little bit go into the simplified version for our viewers. What is this study over there? So it is a technically retrospective trial, and classically 2 by 2, like a 4 group, where this model says vasopressin should be started. Actually, it was started, or actually it wasn't. One group. And where this model say it should not be given, so whether it was not given by the clinician, or even it was given in those subset of the patient where this model says not to be given. That is the 4 things which happens here. Now the here question comes, how this reinforcement learning, you described very well with the illustration over there, but one or two important link here comes when somebody is really little bit having a slight inclination related to the artificial intelligence and the machine learning. So major division in the machine learning and machine learning is one of the type of the artificial learning. Artificial learning is a very, very umbrella term. And the machine learning is majorly divided into the 2 parts. One is the supervised learning, and another is the unsupervised learning. So supervised learning, like you already, we also learned, human also learned the supervised learning. You learn the things in your school or medical school in primary. Those, they are given the instruction, then only you learn, and now you reproduce the things based upon the what you learned from this thing. That your learning was supervised. It wasn't all the time open up. And compared to those days where the human was not having any traditional way of education, like in forest Tarzan and all these things, they learned the things that was unsupervised. So that is the reinforced learning here. So supervised learning, when you already feed the data and all this thing, now the machine use so many data based upon the you feed the algorithm. Now how this or reinforcement learning is different from this is like a video game. You allow somebody to play a video game without giving any instruction. They are not giving, no instruction was there. They just started playing the game and see what is happening. If they are getting the reward, that means they understand this is for me. And if there is some harm, then they set back and keep on doing this thing, and they make their own way while playing. And this is completely unsupervised. Why? Because those parameters which reinforced learning was capturing, that was beyond control from the human or the clinician or whatever you set the data. It's other way around. What the human did in the so many events, roughly 14,000 patients are there, and they observed based upon the outcome what happened to them, and they actually made, and where the reward happens, they captured it, and they make their rule now based upon that consistently the signals is I am getting. So therefore, now subsequently coming challenge for me, for the model. Challenge means the next reading comes over there, and if the model will be asked, should I start a vasopressin or should I not? So based upon what the model learned, they give the answer. And eventually, now probably audience may not be getting the how it is happening. The retrospect already it happens, so it is like a virtual scenario over there. The intervention already completed, outcome already happened, but the software is flooded with so many situations, and based upon that. And classically, this algorithm based upon the 70%, 15%, 15% split base, means whole data, 70% used for the training. And after the training, happens, then 15% of the data used for the validation. So initially the software machine learned after the 70% of those so much used data. Now they 15% validate it. And validation is an internal, external. Internal means you already selected the data, and external means a new data set where you apply the software.
Sir,
Now
one
last,
is only for internal validations. Sorry, only for that UCSF set. No, sir. They did not
Yeah,
include the external validation set.
yeah,
Like
in
that's
this 15% is it. And last 15% is basically your test data. Now you make the impression based upon that is the way, and they categorize in this 4 form, where the vasopression is advisable by the model. Clinician started, then they observed whatever outcome will be discussed, or clinician didn't. In those subset, based upon they already learned what are the right time in the form of epoch and all this thing. Will not go into the detail. So very intricacies over this trial, but the simplified version is now models say you have to start, but clinician didn't, whatever the reason. And another subset, they don't want to start, and the clinician started. So they made a conclusion the both the way. When machine or this model, they not advised and vasopressin was started, so the outcome wasn't favorable even on those this thing. That is my simple learning over there. Dr. Bikash, you want to add?
No, that is okay, sir. But Tamil, because there are so much terminology involved, before proceeding to the actual studies, how they have analyzed that, can you simply make it in a simpler term differentiation between the different types of that? What is a AI? What is a large learning like this machine learning? What is deep learning, or what is LLMs? So these are the terms mostly used. So can you explain differences between those things before we proceed?
No, sir, I am not familiar with that.
So basically, if you think all of these are a part of a data science, because everything that you analyze or have some interference with the data available. So, and if you are using AI in a data science, these are the subsets. So first subset is most of the time you see these are the machine learning, because so as Dr. Jitendra described, so you give some data to the machine, and the machine itself learns. It may be supervised, semi-supervised, or unsupervised, as you discussed. Okay. So then there comes the second set is a, like you say, deep learnings. So deep data that we described. So it is so here they uses these neuronal networks, like you have in a human brain, how you have different set of neuronal networks. So you, though the computer science, the software try to mimic those neuronal networks, will not go into details. So basically, the deep learning is a subset of the machine learning, where the neuronal networks, or they try to mimic the human thinking, or how the brain thinks, and have data. And from their subset, we have a specialized subset, like there is a generative AI that we are using, or large LLM models, the ChatGPT, and those things we are on. So if you broadly say, so there is a data science. Under that subset, you can use a AI for the data science. Under that subset would be the machine learning. Under that subset would be the deep learning, and under which will be the generative AIs or LLM models. So this is the, you can go and read how to those things, but at least you should know how these things are done. So what is the difference between? So these are all subset of one by another. So what in this study they have used a particular type of machine learning, that is a reinforcement model. So here, as we discussed by Dr. Jitendra, so it may be supervised. Suppose you have given a lot of pictures to a to the software, and you want to differentiate between the which one is a apple and which one is a orange. So there are two ways. Either you give, among these pictures, you give an instruction to the machine that this is a photo of an apple and this is a photo of an orange. So based on that, it will classify whatever apple and orange. In unsupervised, you don't give in data. It will itself learn from these things. Okay, this is an apple. Probably these structures are apple, or these structures are orange, or they can categorize and best that. Or if you have give us some data like in semi-supervised manner, you only give this is apple, you will automatically learn about the oranges, something like that. So these are things. And in a reinforcement model, what will happen? You have a target like this study. They have a you have a reinforcement, or you have a something you at each run you have something to achieve. So you have here the lowest mortality rate. They have to go for a mortality rate. That is mostly they have gone the model. So this is again, suppose there is a robot in the room and you want the robot to open the door. So you give the instruction. So reinforcement here will be what is the shortest time or what is the shortest distance. So it will try different models and find out which is the shortest time or the shortest model like this one. So these are the models used here. So we'll go to the proper study. Then one last thing I will everybody, because AI is there in everything. So you talk about the agents. So those are the AI agents. So if you go, so there are three things. One is the AI and why AI workflow, and now whatever is coming is everything is AI agent. So normally what happen? You give some input and it is analyzed by the things and you have an output. So there is a human factor. The input is given by you. So that is the normal thing. So in the AI workflow, which is most commonly used nowadays, is where you attach two, three things. Suppose I want to meet you. So I will attach my calendar with that. So if I ask when I'm going to meet next Tamil, so it will go through my calendar and find out what are the things or something like that. Or I will attach the weather to that. I will attach something, the road to that. So these are the workflow it will go. But with the AI agent, these inputs are not given. This is the software itself who will find out like a human input, what are the possible things that can affect the I meeting you, and it will give a probable scenario. These are the things, or these are the dates with which the weathers, the route, and everything suits me so that we can have a coffee together, something like that. So here they have used these agents who have taken that decision on their own. They're these at this point, if you are intervening with that is the vice president, what will happen? You have some reinforcement for that. They have another trial. At this point, if you are intervening, what is happening? Like that. To make it such, it is not that simple, but I will request all the listeners to at least go to find out what are these terminology, because that in coming futures, you will be using these terminology much more frequently. So we can go to the study proper.
Yeah. So now the third step comes over there is the method. How they did the study. They clearly shown in the form of conventional way of study flow. What are the observations used for that? But the further division was, as I told you, typically 70, 15%. So here your conventional way becomes a little bit obliterated, and we have to follow what machine-based learning applied in the research. So in this way, it was done. Now they express the results and simultaneously they make the correction regarding some confounders or certain e-value test is there, so that impact of confounder can be minimized or bias can be minimized, all these things. But of course, when we discuss about the critical appraisal of the study, then definitely there is a limitation. As of now, we don't have so many tools to really go for critical appraisal. So how to analyze the result? That is also important. Say, for example, conclusion is there. Now, the first question, should I believe in conclusion or not? That answer will be given by the critical appraisal of those things. Okay, for the time being, I believe it. Now, how I apply this, my belief? Based upon this understanding, now clinicians should redefine their criteria and start using the vasopressin. That impression I should make with this conclusion, or subsequently the decision regarding the vasopressin maybe in the clinical practice will be supplemented by the reinforcement learning model. So should I use my conclusion in this way or that way? either clinician should become some more and more intelligent, but the problem is the machine considers so many variables simultaneously. Probably clinicians may not be able to assimilate all the things in way the machine this thing is considered. And second, the limitation over the classical, it is a retrospective. So you are analyzing what you already did it. There may be a certain more possibility on the ongoing evolution of the combination the things are happening that they may not be taken account into this finding only. Then we need to develop all the time reinforcement learning, because every time the same model keep on. So assuming this knowledge will be good enough for the clinician and the staff start taking action. As I told you, this is the typically the lucid kind of this thing. Keep on changing. But clinician, who will guide them? Because this is the one-time solution came with this paper only. Who will guide them? The scenario here, the typical is the environment and agent. So for in clinical practice, agent is the clinician and environment is the clinical thing. That also keep on changing, and nobody will be there to guide them because the guidance was achieved from this model. So these are the few things related. Now audience don't get confused. There the certain projection. Dr. Thamis showed the random presentation of the color coded pictogram where the noradrenaline and the vasopressin. So study was not on the random kind of this thing. Is they select a certain patient to illustration for the random. So don't get confused. The viewers is that means some random study was done. No, the random sample wasn't taken. All the data was taken. Those pictorial diagrams actually they are selected randomly from the machine model to show in this paper. So expression of result little bit here is the you can say hybrid. One aspect we have to take account of the machine-based learning, how to express the result. And second is the classical way of our study and the expression of data, statistical analysis, confidence interval. So both are the hybrid way of expression of the data and the result. And the same way, both are a hybrid way of correction of the problem related to the data interpretation from the machine learning. The rules will be for the machine learning to correction of data, and from statistical, which we know the corrections from the correction from that point of the time, and the limitation clearly defined. So when we go to the critical appraisal, so the critical appraisal of the study and critical appraisal of the paper superficially looks the same thing, but it's not the same thing. We usually, in the journal club, we usually do a critical appraisal of the paper. We can't do the critical appraisal of the study directly. What the author says, and they say we believe upon that, and we try to make the actual events happens what they have written in this. So that is also a limitation for the critical appraisal of the. There may be possibly a more excellent thing happen, and then the author forgot to write it, and there may be they written very nicely and not happen in a way which it has been written over there. So that's why the critical appraisal of the study and critical appraisal of the paper differ. Related to the analysis of the results, I have this much limited understanding during the reading of this paper only. So Dr. Bikash, you want to add more things related to how the results was expressed, and this is probably the more and more trial will come and we become more intelligent in this way.
No, yes, as Dr. Jitendra says, so it is much more complex thing they have analyzed. So how they have done that, Dr. Thamis has given a very brief and very simplistic way of, because if you go and read the study, it will at least you have to read twice to read, understand what is happening, what they have done, because these are the studies which are not, we do practically in our practice, we must do studies which are clinical oriented. So how these models are created and what they have tested. So as Dr. Jitendra says, so basically they have tested those 4 groups where vasopressin was actually started or not started, and that can be started on the basis of the probable model or not started. and they have given different statistics, many of them, to justify what is happening and to validate their data or how to interpret those data. Before that is okay, but before they have used two things. I would like Thamis, if you can describe. So they have done a sensitivity analysis. So can you say what is a sensitivity analysis and what is the importance of sensitivity analysis in this study?
Yes, sir. So basically here it's not a RCT, it's not a trial. So randomization is not done. Basically they have taken the data, it's an observational data. So since it is an observational data, it is prone for confounders, especially unmeasured confounders will be there. So in these kind of patients, we have found one results with with the regression model, we have found the adjusted odds ratio of for mortality. So we don't know how much robust it is, like how strong it is, how correct it is. In RCT, we know that data will be equally distributed and matched, but here we don't know whether it is matched properly or not. So basically, sensitivity analysis is done to check the robustness of the study, like how reliable it is, even if we alter some values. So that is what here in the sensitivity analysis, I can show it in the slide also. So they have done it in certain cohorts. So here, as we can see from the slide, the analysis was done in one restricted, they have restricted some values. Say we can say because of the AKI patients, the mortality is higher or the mortality is lower. So they have removed that patient. Like it can be a confounding value. So they have removed this value and checked whether it is still holding true or not. Similarly, they have checked it is only in vasopressin in whom it was advised, it is showing value significant result. You don't know about the other groups, like in whom the vasopressin was started early or it was started after 48 hours or less than 48 hours. So they've removed certain group and analyze whether the result is same in the other group by restricting the cohort, by eliminating some patients. So this is one way. So this checks the robustness of the study and it rules out the confounding factors. Secondly, they have done with the other models, it can be done with for the robustness, it can be done for e values can also be checked. E value also tells the confounding factors level. Like say some factor is causing is the confounding factor that is associated with both outcome and the exposure. So we have to see what is the risk ratio for that confounding factor. So if it is more than 3, it means the risk is higher with that. So the e value also correspond to that. Roughly, if higher the e value tells that the confounding factor is much associated with the outcome or the exposure. So higher the values, it will be more better. If it is lesser than that, like say it is less than 1, it means the confounding factor can easily change the values that we have gotten. So that is also one of the ways to check for the robustness of the study. Also I've told them like restricting the groups with this much cohort, they have checked with various levels, like the time intervals they have taken in 1 hour. So if they have analyzed it in different time intervals, maybe the outcome may be different. So that also they have checked with 2-hour values. Also they have checked with the since it is observational data, they have given weightings for equal for each variables. So what if they have changed the weightage? So they have changed the weightage for this each variable and checked whether the result holds true with that also. Also, they have checked with the different gamma levels. They feel since they have kept the gamma level as high, it has performed like this. So what if the gamma levels was like, it was not kept for the long-term rewards? What if it is kept for just the short-term rewards? So if it is reduced, whether this mortality difference is coming or not. So basically to check the confounding factors and to eliminate that part, they have done different data analysis. So sensitivity analysis tells that only, sir, to check the robustness of the result by eliminating some values. Some apart from this, we can do for the missing data also. Sometimes the missing data will change the outcome also. Or like the some saying sicker patients with a high SOFA score or something like that, they can change the outcome and they can be a confounding factor. So that can be checked with the sensitivity analysis by eliminating them.
Yes. So basically, sensitivity analysis is a method mostly you use to determine if you change the input variables, what is happening to the output or the model or the system that we have generated. So it is also something known as what if analysis. So what if this
What if?
yeah. So mostly, as you told, it is mainly to find out what is the most influential factor in this system or the model, or to check the robustness of the model, or to find out any decision making or any specific set of scenario where you can affect that. And these are the, you as described, these are the different aspects in which they have done the sensitivity analysis to find out whether these things will going to affect the model that they are predicting or not. Yes, Dr. Jyotendra.
Yeah. So most important thing, of course, this is the classically retrospective trial where the adjustment was done to achieve to actually the simplistic way to define the research is to reveal the concealed truth in the universe. That's so you have to crack that truth, whether to go from this side or right. So what happens if you are having a very large data set, even the retrospective, and you correct in all the aspects from the 360-degree of one side, because the outcome has already happened. You keep on doing the adjustment and you can still hit the truth in a right way. Probably your poorly designed randomized control trial may not be able to give the correct answer. So just saying the randomized control trial superior all the time, and the why I'm using here, because the paper actually nowhere written the retro, because once you use the word retrospective, it sounds so very it gives you a different flavor. That's why. So technically database, once we say database, basically it is a retrospective, but not labeling it as retrospective because the large database and the correction was done, and to see the effect from the different angles, to I eliminate this is a simplistic, which you can use the e-value for the confounder. Then you can directly remove that part and see it, remove that part and see it. The consistently you are getting the signals. So what I take result and the conclusion this thing is definitely there are the signals of use of vasopressin, and of course this is a typically binary kind of this thing. Use it, don't use it, use it, don't use it. I will not go into the how to use it, how to start it, what is the infusion, right from the higher to the lower down, or the from lower to the up, and all these things are variable. This is just a very simplistic way where it looks like there are signals to start the use the vasopressin quite often, which still we are not using. That is our understanding, and I think we can go for the critical appraisal now. Of course, we don't have a very well defined tool for this type of trial, but at least try to see how we can appraise this paper. At least paper we can appraise it.
Yes, Dr. Thamis, please go to the
Yes, sir.
critical appraisal part.
But very nicely presented, Dr. Thamis, with so much complexness. And the most important why when we selected this journal club is actually the one aspect we gain the knowledge, and our student gain the knowledge, is related to the uses of the AI. Now the clearly even somebody attend this journal club, they can easily write the short notes in their exams. This journal club gives the clinical use as well as the research use with the so much simplified way that Dr. Thamis explained. Yes, Doctor, continue.
Coming to the critical appraisal, coming to the study design, whether the research question, basic research question was clearly defined or focused. Yes, it is defined. Basically, they wanted to see the timing, optimal initiation timing of vasopressin, and whether it is associated with any mortality benefit. So that they have clearly defined.
Just
so whether,
I add over there. What
yes,
is the example of inferior over there? Suppose some study collected the data from this thing. We just collected the data and presented over there. So that was an inferior point over there. Now here the clear cut defined. Just to give the contrast, when we say it is not clearly defined or ambiguous, is if somebody collected the data just and presented over there. So that was would be no over.
Okay.
Yes.
Are the derivation cohorts and the validation cohorts drawn from the similar population. Yes, they have used that UCSF data set for the derivation of the model. After that, they have checked the validated in the same cohort also. Also, they have validated in the external validated set also. So whether the inclusion and exclusion criteria clearly stated, yes, but inclusion criteria they have stated, but exclusion, which all patients they have excluded, but they have not stated clearly in the study. So where the exposure measured in a reliable way, yes, they have measured and they have mentioned that 14 values also, where outcomes clearly defined and clinically relevant. Yes, the outcome parameters were clinically relevant: mortality, RRT, mechanical ventilation. Coming to confounding and bias, where their potential confounders identified and appropriately adjusted for. Yes, there, since it is observational data, there are multiple confounders, uh, especially unmeasured confounders, and from that patient characteristics also, we have seen all the data were not so much comparable. So whether it is appropriately adjusted for. Yes, they have used adjusted odd ratios and they have done many other sensitivity analysis also for adjusting. Where missing data handled properly, that they have not mentioned clearly. They have mentioned that missing data, for the missing data, they have used last observed values, or if no values are there, they have just used the mean of those values. But they didn't mention what they did for the missing data, whether imputational analysis was done, other parameters that they have not mentioned. So coming to model validation, was since it is a model-based study, so some points regarding model validation, whether external validation and internal validation perform. Yes, both were performed. For the model performance compared between the derivation and validation cohort. Yes, they have compared the model performance in the internal, in the derivation cohort and the validation cohort with the data that I have mentioned, lab values, vitals, and the clinical parameters. They have compared both. Was the performance metrics measured, like AUC, calibration plots, or prior score? That they have not measured. They have used one algorithm, but what algorithm they used and whether it is, they have tested an external validation set, but how much is reliable, like area under the curve or the score for that metric is not mentioned. So coming to analysis, where appropriate statistical analysis were used, yes, they have used appropriate statistical analysis in multiple ways. Was the confidence interval and the effect size were reported? Yes, it was reported in all analysis. Was sample size adequate for the predictors and outcome? Yeah, they have used 14,000 patients. It is adequate. For sensitivity analysis or the subgroup analysis performed, yes, we have seen both sensitivity analysis and subgroup analysis are performed. So coming to interpretation and generalizability, where the result interpreted with limitation, yes, they have interpreted. Even they have told that since it is not a prospective study, that they have included it in the limitations. Whether this model is generalizable to local population or setting, whether is it applicable to our setting. So this, I would say, maybe, like they have also mentioned that it is not generalizable to low and middle income countries. Also, from this study, we know from the start, the research question is whether the optimal timing of initiation is known or not known, when to start. That is the question. Here, they have used an algorithm to start. They have predicted what if the clinical parameters like lactate, MAP, SOFA score were like, or dose were like this when at the timing of starting vasopressin, and how it results in the mortality that they have mentioned. But they have not given a uh, algorithm or model what they have used, like what should we use, when should we start, what should be the norepinephrine dose for initiation of vasopressin is still not clear after this study. So what should be the SOFA score at which we have to start? What should be the patient duration of shock onset at which we have to start? They have mentioned that it is started at this point in that study, but whether that gives you a better idea, that is not mentioned clearly in the study. Thank you.
So that
Excellent, Dr. Thami. Just again show the slide, the second last, before statistical, before that. Yes, yes, yes. So this is a very nice way. Actually, as I told you, the two aspect over there. One is the data statistically, and then so this is the classical how the machine learning actually appraise or the how you can go their reliability. So these are the tests based upon the machine learning goes for the whether you can rely on the results or not. So you actually assimilated in a nice way and presented here as a part of the critical appraisal. So that's what I was thinking how to appraise here, but you definitely used that very logic and relevant way, because one, we have to appraise that thing which what they're saying is correct or not. And then the second aspect is the once the data is there and then you represent in the form of a statistical analysis, that part is the convention. So this is very a good slide, especially those viewer again for the not only from the paper point of view, even the machine learning and all these things. So these parameters actually should be taken care in a way. And how it can be done, that is a long question for that.
Yeah.
Yes,
So
Dr. Bikas.
two things I like to add, sir. First of all, the critical appraisal is good, but whether this is a adequate enough critical appraisal for this type of study, I have one doubt. So, like when you go to in a normal study, when you critical appraisal, you say you look out whether these statistics methods are used or appropriate or not, like that. So, in this type of study, whether the AI agent or AI tool that has been used, whether they are appropriate for not that, uh, we don't know exactly, or we don't have the expertise to find out if these. At least that
At this moment,
yeah.
obviously, that's the problem. Like when we use the petrol based or the diesel based, when you use the word the mileage, and then suddenly the electrical vehicle. Now you don't know how to go about that.
Yes,
So you need to develop about that, and you can't apply the
yes, yes,
tennis rule in the football. So
so
definitely you need to learn
They
their
have
rule.
mentioned, sir, they have mentioned in the methodology that they have used that tripod plus AI guidelines.
Okay.
So for
but we don't know
validation,
whether
model
that is a
validation, yes, sir, but they have not given what they have analyzed, what is that guideline properly. And I have
or
actually searched.
whether any better guidelines existed for that. We don't know those
It's a
things.
tripod is the normal guideline that is for that any model validation के लिए. But they have used tripod plus AI. I think probably just for this machine learning only they have added this. So since they
And
have mentioned.
Yes, sir.
even to really think about the generalizability on the patient, I think still here is the whether the clinician believe or not, that should be a generalizability over there at this moment. Going for the patient application, that's the separate issue. Here what we can say is the success is the really clinician agreeing with this results or not.
So
That would be a
second point I want to highlight is the same thing. So whether the generalizability or not. So even after the study, as you there are a lot of limitations or something like that. One thing we can have an impression or signal that maybe static vasopressin earlier is helpful. So, in which patient, at what point, those questions which are unanswered in the at the start or at the beginning of the trial, also they still remains, because you, as per the model, you can start at certain point, but these are not validated, or it cannot replace because there are multiple factors which affect the outcomes.
Yeah,
So,
that's the beauty and the disadvantage of the
yes,
unsupervised learning. Beauty is they themselves come up with this thing. The disadvantage is even you want to take out the based upon this thing is there so much complex over there. They started maybe giving a weightage of this thing is some not only the presence of the two or three or five factors, one factor, then the presence of two factors, and what is the weightage. They keep on changing and all these things. That's why even if we want to take the help of this machine learning, their algorithm from their takeout, so now can the it can be guided how they make their algorithm, is it won't be that much straightforward, because this is so unsupervised learning, they may keep on making their more own neurological connections and the based upon this thing, and they keep on changing the weightage also. So sometime a presence of hypotension or mean arterial pressure 55 may carry a different meaning. One may not be equal to 2 here. So that is the a problem at
yes,
this stage. So anyway, it's a very a nice way to deal with this general and the presented by Dr. Thamizh.
Thank you,
I
sir.
really congratulate him. It's not a simple study where we present just a method and the results, and very well explained how the things happens, and simultaneously it opens the door of the altogether a vast way of going for the research. Our a typical mindset, prospective randomized control, or of course randomized control all the time would be a prospective randomized control trial, and the case control is nothing. So again, the things are going to be a little bit not that binary division which we are
Yes.
thinking. Large database, and then now the same thing can be a prospective also. So similarly, once your model is ready, you can start using it prospective without changing the clinical practice. Just let the clinician manage in their own way, but they apply the data on the forthcoming now the prospective way, and how the model is. I know you can blind also, because they require input on just the data only. So clinician do their own way, and they keep on suggesting, and these things can also be done prospective without harming the patient.
Okay, that's it. If everything is okay, we can conclude, sir.
I think.
Yeah.
Yeah.
Okay. Thank you, Tamiz, for the best.